Hi, everybody. I'm Dr. Kristi Maas with Reproductive Care Center. We see patients throughout the Salt Lake Valley area with 2 offices in Clearfield and in Sandy. We also provide care to patients or individuals throughout the Rocky Mountains, and we're happy to see you and answer your questions and help you in your fertility preservation and family building journey in any way we can. The topic that we're going to discuss today is PCOS, which stands for Polycystic Ovarian Syndrome. It's actually one of my least favorite terms because I feel as though it doesn't adequately represent the disease. People with polycystic ovarian syndrome actually do not have multiple cysts on their ovaries. They actually have multiple follicular cysts that do not grow and ovulate an egg. So it's really a disorder of ovulation more than a disorder of cysts. A follicular cyst is something that is there in every ovary that has potential to ovulate. And it is something that we grow a dominant one each month to ovulate the egg. Whereas in PCOS, that dominant one does not grow. You don't ovulate, and because you do not ovulate, you do not have regular periods or have irregular bleeding. So that's the central tenet of PCOS, or polycystic ovarian syndrome, is irregular periods or no periods. And this is actually quite common. Around 5 to 10% of patients may experience PCOS or PCOS-like symptoms. PCOS is technically a spectrum. So there's people that have very severe PCOS and people that have very mild PCOS. There's different manifestations of this. And this is actually a very treatable condition as well. And then the last component of PCOS is elevated androgens, or kind of male steroid or androgenic steroid hormones, either by symptoms or by blood work. So these could be elevations of your total testosterone hormone level, your free testosterone hormone level, could be elevation mildly of a hormone called DHEAS. If that hormone is markedly elevated, then we're more concerned about an adrenal gland problem. Or it could be based on symptoms. Common symptoms of elevated androgens include things like acne or hair growth, and hair growth in places that we don't really usually desire to have hair growth. So maybe on your face or your chest or your back or your navel. And this is thick hair growth, usually not those kind of fine little baby hairs. Rarely you can get things like androgenic alopecia, where you get some balding of the areas on your head. It could be things that are even less common, where we get an enlargement of the clitoris. And in very severe androgen exposure, you can have the clitoris be so enlarged that it actually looks like it's in between a clitoris and a penis. And that's called clitoromegaly. That's very uncommon, and that tends to be associated with other diseases, more so diseases that are associated with adrenal gland abnormalities. Unfortunately, patients with PCOS are more inclined to gain weight than patients that don't have. So if I were to eat a cheeseburger and a patient with PCOS were to eat a cheeseburger, the patient with PCOS is more likely to gain weight from it than I would. That said, it's a little bit of a catch-22 because weight control and weight management is markedly more important for a patient with PCOS than someone that doesn't have PCOS, because that can help with menstrual regularity. It can reduce the disease severity of PCOS. Of note, not everybody with PCOS has an elevated BMI. There's a polarity of things, and there actually is a subset of PCOS where people are what is called lean PCOS. So even if your weight is normal or underweight, that doesn't mean that your irregular periods are not PCOS. You could have a different subset called lean PCOS. Individuals with this lean PCOS are at increased risk for diabetes, high blood pressure, high cholesterol, just like patients with traditional PCOS, even though they are leaner and do not have increased rates of cholesterol or fat on our body. We do know that people with PCOS also have increased risks of other diseases. We unfortunately don't yet know if there's a genetic link or if there's a deeper underlying cause of this, but we know that we see increased risks of things like high blood pressure, diabetes, high cholesterol, regardless of whether or not someone has an elevated BMI or a normal BMI. We also know that this can be associated with mood disorders, things like depression or anxiety. For patients that do have PCOS that have irregular periods, it's very important that you protect the lining of the uterus. So if we're not routinely shedding the lining of the uterus, the lining will become thick. The cells that line the uterus can become atypical or abnormal. What we mean by abnormal is they can become precancer or cancer, especially if it's been a very long time since the lining of the uterus has been shed. So for people that have PCOS or irregular periods, you either need to be trying to achieve pregnancy, which we do by helping with ovulation induction, or you're not trying to get pregnant, but we're taking medications to protect the lining of the uterus. These would be medications that include the hormone progesterone. So that would include things like combined hormonal contraceptives, whether that's a pill, a patch, or a ring. It could include things like the injection. It could include things like an IUD or the implantable birth control that contains progesterone. All of those keep the lining of the uterus from becoming thick, precancer, cancer, or abnormal. Now, one thing to know is an IUD needs to be a hormonally containing IUD, where a copper IUD will not prevent this for general health and well-being. And when people come to see me, they often ask, well, I've been told maybe I have PCOS, but I don't know. I don't know if I've even had testing for it. And so let's get a little bit into the basics of what PCOS is medically by definition and how we actually diagnose you for it. PCOS is technically something that we call a diagnosis of exclusion, meaning you have to rule out a multitude of other diseases that can manifest with similar symptoms and act similarly. These would be diseases of other glands, like the pituitary gland in your brain, your thyroid gland in your neck, your adrenal gland in your abdomen. So we have to do testing to make sure it's not abnormalities of other glands that are mimicking PCOS symptoms. That's testing your thyroid hormones, your adrenal hormones, your pituitary hormones. Then we also test ovarian hormones. Some of our ovary hormones also overlap with our adrenal gland hormones. Those types of hormones are things like testosterone or our adrenal androgens, can also be produced by the ovary as well. We test to see if the testosterone levels are elevated. We test to see if the ovary is producing estrogen or progesterone after ovulation. And then we combine the testing of the ovary along with an anatomic assessment to say, hey, do the ovaries look polycystic in appearance? And again, this isn't an ovary that has recurrent cysts or recurrent ruptured cysts or multiple cysts. It's basically an ovary that is chock full of eggs, but it isn't ovulating eggs. And so we look with an ultrasound, and the ovary is described as having a ring of pearls appearance to it, meaning there's lots of little follicular cysts on the edges or the margins of the ovary, but there's not one that's the big one that's the dominant follicle to ovulated egg. We also look at the size of the ovary. The ovary for people with polycystic ovaries tends to be larger because it's just really stocked full of eggs. It is commonly misrepresented that people that have PCOS will never be able to become pregnant or will always have challenges. And yes, 70 to 80% of people that have PCOS do have challenges achieving pregnancy. And this is primarily because if you're not ovulating an egg, then there isn't an egg available to be fertilized by sperm to create an embryo and create that pregnancy. That is usually very easily treatable with medications that we call ovulation-inducing agents. And there's a multitude of different types of medications. These are medications that could be taken by mouth. You may have heard of things like letrozole, also called Femara, which is a pill, or another medication called Clomid or clomiphene citrate, also a pill. Rarely we need to add on injectable medications that mimic the hormones from the brain that stimulate the ovary to get the ovary to grow if someone has very resistant PCOS. And we know that having even a slight reduction in weight for people that do have an elevated BMI can help with treatment. So even 5 to 10% weight reduction can improve ovulation or egg release for patients with PCOS. So we really want to focus on optimizing lifestyle. You want to eat a healthy, well-balanced diet. You don't want to do a crash diet. You ideally want to avoid the processed foods. You want to avoid the really fatty foods or the really simple carbohydrates, things like sugar or Doritos. I've recently encouraged people to consider things like a Mediterranean diet, or even thinking about what I kind of term the farmer's market diet. So if you can't pick it up from a farmer's market, try and avoid it or eat it in moderation. So this is getting you focused on those whole fruits, whole vegetables, grains, lean, fresh meats, and that's going to be a better, healthier, well-balanced diet for you. Even if you're not ovulating your eggs, unfortunately, that doesn't save them for the future. We're born with every egg we'll ever have. The quality and quantity of these eggs declines with time. And we churn through about 1,000 eggs every single month, whether we're ovulating one or not. So unfortunately, PCOS patients aren't saving their eggs for the future, but they generally have higher egg counts, higher ovarian reserve, than other people of the same age that do not have PCOS ovaries. As I mentioned a little bit ago, the main impact that we see in our office is that lack of ovulation impairs the ability to create a pregnancy. And so we can treat that again with ovulation induction medications. Very rarely people will do surgery for this, where they're actually ablating or removing some of those small follicular cysts on the edges of the ovaries via laparoscopic surgery. Other options, you could do things like IVF, although most patients with PCOS do not start off with IVF. They are generally good candidates for IVF, but do have some increased risk of complications like ovarian hyperstimulation syndrome, which your doctor should make you aware of, as well as manage your treatment and your protocol in a personalized way to reduce your risk of this. Other components that you may read about are medications such as metformin, which helps with insulin sensitization. So patients, as I mentioned previously, have an increased risk of diabetes. And this can help reduce the risk of insulin resistance or diabetes. It's also been shown to improve menstrual regularity. But with that, metformin alone does not increase pregnancy rates. You have to combine that with a medication, preferably letrozole or Femara, to improve pregnancy rates, even if you are cycling regularly and ovulating. Other supplements like inositol or myo-inositol can also help with insulin sensitivity and help with menstrual regularity. But again, these should be used in combination with ovulation induction agents to help you achieve pregnancy. Many times patients are working with their primary care provider, a dietitian, a nutritionist, or even an obesity specialist to help optimize their weight. With this, we're seeing an increase in patients using the GLP medications like semaglutide or tirzepatide. which can be very beneficial with weight reduction. That said, these medications are generally not recommended in pregnancy. And with weight reduction, you may see increased ovulation, and you can go directly from having irregular periods, no periods, not ovulation, to pregnancy without having a period. So while you're on these medications, it's important to communicate with the prescribing physician, as well as your gynecologist or reproductive endocrinologist, that you're on the medications and your family building goals, and that you either contracept or have an awareness that you may conceive, and the second that you know that you're pregnant, you discontinue the medications. Additionally, if you're having any surgery or procedure, we want you off of those about 2 weeks before the procedure. So my patients going through IVF would discontinue those medications with the IVF medication start. Or those patients going through treatment generally are discontinuing medications because we're getting them through the treatment phase and anticipating pregnancy. Again, talk with your prescribing physician about whether or not this is something that you should be taking while you're trying to conceive, and when you should discontinue it given your treatment plans and your goals. So the most important thing is to communicate with a doctor if you're having irregular menstrual cycles and have the appropriate testing, which we do here at Reproductive Care Center, and we're happy to do for you. Think about the health of the lining of your uterus, making sure we're preventing it from becoming abnormal. Thinking about your general health and well-being. And unfortunately, patients with PCOS should not be in the not trying category of trying to get pregnant, meaning, hey, I'm not really taking medications to try to get pregnant. I'm not doing anything to prevent it. So if it happens, it happens. And that's a concern in patients with PCOS because with the irregular cycles, that lining can become thick and abnormal. If you need anything, myself, my team members, my staff, we're all happy to help you in your journey, answer whatever questions you have, help you find that diagnosis so that you know what your diagnosis is and that we're treating that particular diagnosis, and then working with you to provide a personalized treatment plan to help you achieve your family building goals. Thanks for taking the time. Please reach out to us at any time at Reproductive Care Center.